This is a presentation for individuals practicing in departments of anesthesia or anesthesiology who may be interested in participating in the craft study. The purpose of the study is to determine the impact of using a deliberate teaching tool to teach junior doctors in anesthesia. Depending on where you practice medicine, these junior doctors may also be called trainees, residents, registrars, medical officers, or senior house officers. Similarly, I use the term anaesthetist to mean medical doctors with completed specialist training in anesthesiology, while some of you may use the term anesthesiologists. We think that two simple changes to how we teach may have significant positive impact on the educational environment of trainees. These changes are determining mutually agreed learning goals prior to the start of a list and giving feedback at the end of each list. Now, there are a few phrases here that may not be familiar to everyone, such as deliberate teaching tools, educational environment, and advocacy inquiry. I will explain what these mean as we proceed with the presentation. There is no agreed definition for deliberate teaching tools, but a colleague and myself have proposed one in a review article that has been recently submitted for publication. Deliberate teaching tools are models that enable clinicians to have a purposeful and considered approach to teaching encounters by adopting traits identified with good teaching practice. They've been around for over 20 years and are also taught on the ANSCA Educators Program for use during clinical teaching. Well-known deliberate teaching tools include the 1-minute preceptor and SNAPS models, and more recently, the BID model. There are over 20 deliberate teaching tools in published literature, and most are designed for family medicine or ambulatory clinics. From our extensive literature search, no deliberate teaching tools have been evaluated in clinical anesthesia. What's the rationale for using these tools? Most teaching in the operating theatre currently occurs in an ad hoc fashion, where the supervisor decides what to teach based on the type of anesthesia for the surgery, the patient's medical background, or perhaps their own area of interest. Some supervisors do ask their trainees about teaching topics, and some trainees are explicit about what they'd like to learn, but this is not the norm. Opportunistic teaching also occurs for events that may emerge during the course of the case, such as management of hypoxia or perhaps an unexpected difficult airway. Clinicians rarely give routine feedback at the end of each list, despite there being strong evidence in the literature that feedback on specific events, whether positive or corrective, should be provided soon after the event, as opposed to a mid or end of placement feedback session by another individual with second-hand information. The CRAFT deliberate teaching tool is designed to address these specific aspects of the teaching encounter. Workplace-based assessments that are commonly used in the operating theatre include the Mini-CX and DOPS, or Direct Observation of Procedural Skills. There are some similarities between deliberate teaching tools and WBAs, as they both facilitate teaching. But deliberate teaching tools focus on teaching and learning, while WBAs place an emphasis on formative assessment. This Venn diagram shows how deliberate teaching tools and WBAs relate to each other. With deliberate teaching tools, there is no scoring of the trainee's performance, there's no form to fill, and it's designed to be used routinely in all teaching encounters. I will, however, acknowledge the important role of WBAs in many vocational training programs. This study is designed such that participation will not disadvantage any trainee who needs to perform WBAs as part of their training requirements. The model was developed after an extensive literature review. It is designed to be simple to use and is comprised of three phases. The pre-brief phase is a short encounter prior to the start of a list to determine the trainee's experience relevant to that list and to determine mutually agreed learning goals. In essence, it's asking the trainee what they'd like to learn or get out of the list for that day. For the second phase, we don't actually dictate how the teaching occurs, as each person may have their own style of teaching that suits them. However, the previously agreed learning goals should now serve as a guide. And of course, opportunistic teaching for something that unfolds during a case may occur as it usually would. The debrief phase employs an approach commonly used in simulation teaching to deliver feedback, called the advocacy inquiry approach. Most deliberate teaching tools and WBAs involve the provision of feedback, but they don't give you a structure on how to provide that feedback. I won't go into too much detail, but the instructions for using the craft model has some clinical examples on how to use this method of feedback delivery. There is also a provision for specialists to use alternative methods to deliver feedback if they are more familiar with them. We think this area is important because many clinicians don't routinely give feedback to their trainees, especially when it comes to corrective feedback. What happens more often than not is that they defer this action to the supervisor of training, which may result in a situation where the trainee continues to perform the undesirable behavior until such a time when the supervisor of training actually manages to have a conversation with them. I suspect that this is because many clinicians find providing direct feedback quite a daunting experience, especially when it comes to corrective feedback. A study by Jenny Weller and colleagues published in the BJA in 2009 essentially confirms this in relation to WBAs. We have listed here the two objectives of this study. Because we are still in the pilot phase, we are also looking at the feasibility of the study and the levels of outcome variability in order to determine adequate sample size. This is a linear comparison study whereby the educational environment is measured before and after the introduction of the craft model. The intervention period lasts 4 weeks and only applies during normal working hours. We will measure the educational environment with a tool specifically developed for this purpose using a Delphi technique, which is a structured method of gaining expert consensus. In this case, our experts were 24 specialist anesthetists who also had formal qualifications in medical education. The pilot phase of the study will also serve to validate the educational environment measure by allowing us to perform an exploratory factor analysis and remove any redundant items in the measure. I'd like to take a minute here to explain why we are measuring the educational environment, as opposed to something more obvious to us, such as teaching or learning. To measure the quality of teaching, we would have to either place observers for each teaching encounter or record these teaching encounters for review at a later date, using an appropriate tool to rate the quality. This is extremely resource intensive and would not be able to obtain adequate numbers for any meaningful conclusion. More importantly, I think, is that we would not be able to control for the Hawthorne effect, which is where the teachers modify or improve their behavior purely because they know that they're being observed. With regards to measuring learning, the gold standard that we currently use is summative examinations. With so many confounders, it would be very difficult to conclude that any difference in exam performance was due to a single intervention, unless that intervention was applied for much longer periods, such as 2 to 3 years or even the entire duration of training. Lastly, we decided not to use a comparison group within a department because it would be near impossible to blind other specialists and trainees within the same department from the intervention, especially when they would see posters on the walls. This is a figure outlining the timeline involved with the department participating in the study. As you can see, It's not a huge commitment time-wise. We have some very basic inclusion criteria listed on the slide here. For departments that have doctors employed as fellows, they may also participate in the study, and a conversation would need to be had with the study investigators to determine whether these fellows are placed in the specialist group or the trainee group, depending on how their role in the department is structured. Individual participants will receive reading material on how to use the craft model, which will include advice for specialists on how to deliver feedback using the advocacy inquiry method, along with some clinical examples. There will be reminder cards provided to all specialists participating in the study, and we will distribute posters to be placed in operating theatres where appropriate. There are a number of reasons why we think it may be beneficial for departments to participate in the study. Firstly, your trainees will likely benefit from teaching encounters having added structure. It's quite possible that best practice education traits may be embedded into teaching encounters for continued use by your clinicians. This study is evaluating a deliberate teaching tool specifically designed for clinical anesthesia, something that hasn't been done before. It would also be the first multi-site international study to validate a deliberate teaching tool, which would promote our specialty as a leader in medical education. If you're interested, talk to your head of department and supervisor of training. Show them this presentation, then contact us using the email address on the screen. This is the process that follows once a department has enrolled into the study. I won't go into detail here, and you can read this diagram at your leisure. The key points from this presentation are that deliberate teaching tools are already recommended to be used for teaching, and that they are not an entirely novel technique, although they may be unfamiliar to many. The study protocol involves only two very simple changes to the way teaching is approached, which are agreeing on learning goals for the list and giving feedback at the end of the list. Lastly, it will not interfere with any WBA requirements that a trainee may have, as the study protocol dictates that the model will not be used if a trainee requests a WBA to be performed. Thank you very much for listening, and do get in touch with us if you have any questions or you'd like further information about participating in the study.